Good.
Yeah.
Okay, so our project is a drug-eluting artificial bifrost graft, and this is our value proposition number 2. I am Alyssa Webb.
I'm
I'm Nicole Racca.
And I'm Emily Sansoucy.
So first, we wanted to outline some of the patients that would need this device. So patients that require bypass surgery will have a blocked or narrowed artery, and this needs to be treated to restore blood supply to the heart muscle. And then patients with this disease can experience the following symptoms: dizziness, chest pain in the shoulders and arms, difficulty breathing, pale skin, sweating, arrhythmias, and nausea. So why is it important? Over 500,000 bypass grafts are performed each year, and this number is expected to increase with the aging population. About 40% of vein grafts fail within 18 months. And obstructive coronary artery disease patients can benefit from bypass grafts because it's a form of treatment for this disease due to the buildup of plaque and blockages in their artery. And most needs for an artificial graft concern the lack of or unsuited veins.
Artery is more invasive than the use of hand, and therefore require a non-recovery time. What will have a higher rate of advance. We are not inhibiting all little bypass that had a one in the area.
So yeah, as Julianna said, we are proposing an artificial bypass graft that's made of PCL and seated with the patient's endothelial and smooth muscle cells. The device will also incorporate the release of 2 drugs, an anti-hyperlipidemic drug called Pravachol and an anti-inflammatory drug that's called Durlaza to reduce the buildup of lipids and to prevent inflammation. Studies involving the combination of these drugs have shown a decrease in the risk of heart attacks and strokes, and also showed that the side effects attributed to each drug were not increased. In terms of drug release, we aim to release the drugs with the degradation of the PCL, which has a degradation time of 1 to 3 years. The oral release for Durlaza is 162.5 milligrams per 24 hours, and for Pravachol, it's 10 to 40 milligrams per 24 hours. In terms of the targeted delivery for our device, we'd have to conduct experimentation to determine the correct amount of each drug needed in our device to achieve a desirable release rate. We are also going to implement 2-stage seeding, where the cells are harvested from the patient and cultured in the lab prior to be seeded to the device. And some limitations of this approach are the lack of research on targeted release and also the time it would take to culture the cells. Our clientele estimation is 200,000 patients per year, as this device would help those with previously failed bypass grafts, and funds for the device would be provided by the insurance companies.
So shown here is the breakdown of cost for a device, and this breakdown constitutes all of the cost for all individual materials and previously discussed. The PCL will be seeded with endothelial and smooth muscle cells, and also then the entire graft will be coated with Pravachol, which is a brand name Pravastatin, and Durlaza, which is a brand name aspirin. So when factoring in all these costs, along with additional lab and preliminary cell culture costs, our device is approximately $36,160.
The hardly on the is hardly that you not hold. The higher up being with OPAD you need by that holiday.
So current treatments of coronary artery disease are focused on reducing the symptoms of angina and prolonging the patient's life. There are oral drug therapies, angioplasty with stent placement, and coronary artery bypass surgery. An important distinction is that our device is not intended to serve as a replacement for oral drug therapy or stents, but is instead recommended for patients for whom coronary artery bypass surgery was deemed the best treatment plan by healthcare professionals. Currently, there's no FDA-approved artificial bypass grafts, but there's a significant amount of research being done, and there are several in development. Some examples are a hybrid bypass graft, a tissue-engineered bypass graft, and a drug-eluting degradable prosthesis. All of these grafts are composed of a flexible polymer to allow the pulsive flow of the blood, and the first two make use of tissue engineering techniques. And then the third is designed to release anti-inflammatory or anti-proliferative drugs.
So our synthetic bypass graft is preferable to the traditional autograft procedure as it doesn't require the removal of a healthy vessel from the patient, and it also removes the risk of complications or infections at the donor site. Along with this, it's targeted for drug delivery and is a drug delivery mechanism aiming to reduce infection and stenosis. And if our solution is not implemented, coronary bypass surgery will continue to be hindered by these shortcomings.